Welcome back to another episode of Single Payer Radio. We broadcast our program from the historic Habron Building in downtown Louisville. The show is a project of Kentuckians for Single Payer Healthcare, and we're an affiliate of the Kentucky chapter of Physicians for a National Health Program. We have this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, single-payer healthcare system. Everybody in, nobody out. The views and opinions expressed on our show are those of the speakers and not the station. I'm Mark McKinley, a volunteer with the group. Single Payer Radio can be heard on WFMP 106.5 on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. If you can't pick up our signal, you can live stream us at forwardradio.org. WFMP is an all-volunteer station. We rely on the community for your ideas and our funding. Join us, forwardradio.org. Got the doctors Mike Flynn and Gene Shively back in the studio with their guest, Mike.
Yeah, this is Michael Flynn, a retired surgical oncologist from the University of Louisville. Let me begin with the usual disclaimer that any comments I make during this program represent my personal views and do not represent the views of the University of Louisville or the Department of Surgery. Our topic today is addiction and pain management. We have a special guest, James Patrick Murphy. Pat has been on this program at least on two previous occasions, and we've had a really good conversation about these really important issues which have become major health problems in this country today. Pat got his medical degree from University of Louisville, did an internship at Naval Hospital San Diego, psychiatry, was a flight surgeon in the Navy, did an anesthesia residency at U of L, pain medicine fellowship at the Mayo Clinic, is combined board certified in both pain management and addiction medicine, and has a Master of Medical Management from the University of Southern California Marshall School of Business. And Pat is the medical director of the Murphy Pain Center in New Albany. Pat, welcome, and thank you again for coming back on this program to talk about these really important issues. It's really scary what's going on in this country with the drug and the addiction problems that we're dealing with. As we've done in the past, we're going to give you an opportunity to make whatever comments that you'd like to make about these issues, and then for as long as you want, and then Gene is going to begin with the first question. So the floor is yours.
Thank you so much, and I really appreciate the opportunity to be here, and I support what you're doing here, and I'm glad to be part of it. I have a disclaimer as well. I'm a member of various organizations, and I am on the faculty of the University of Louisville School of Medicine. I'm on the volunteer faculty. I'm also on the board of directors of the American Society of Addiction Medicine, and I'm on the board of directors of the Kentucky Harm Reduction Coalition, amongst others. And I have a private practice in this area as well. And the opinions that I'm going to express are my own, and they do not necessarily reflect the official opinions of any other organization. Having said that, this is a subject that is on most people's minds, at least it should be, because we have record numbers of people dying every year from addiction. And you notice maybe that I didn't say opioid crisis. I didn't say prescription drugs. That era has, in a sense, gone past us. It's still an issue, and people can still have a problem with these medications. And in some cases, they might be overprescribed. But where we are now, we have a crisis that is more deadly than it's ever been. and it's fueled by more powerful drugs. Fentanyl, for example. Fentanyl is a synthetic opioid that we use in surgery a lot. Probably the most common pain medicine that we use during surgeries. That's coming across our borders. It's being manufactured. It's coming in illegally. It is not medical fentanyl, but it's the chemical fentanyl. And there's other variations of that drug as well. And also, methamphetamine is rearing its ugly head again. Methamphetamine is being showing up in so many more overdoses, as is cocaine again. So these are stimulants that are causing people to become addicted and to die. And we're also finding there are adulterants. There are other bad chemicals that are being put in the illicit drug supply that people are using, and it's causing harm. One of those drugs is called xylazine, which is a horse tranquilizer. It's a veterinary drug, but it's very powerful, and that's being combined now with the fentanyl and the heroin that is being brought into our country. So people that have found themselves addicted or using, or just people that unfortunately are experimenting with these medications, or maybe somebody who thinks they're buying or taking a Percocet or some just pill that looks like a normal pill but is a counterfeit pill. People that are getting and using these drugs are getting, in many respects, these adulterated, these counterfeit pills, these counterfeit drugs. They're not getting what they think they're getting, and they're dying as a result of that. So we really have to see this as a public health issue. I mean, over 100,000 people are dying every year now from addiction, from this overdose crisis. I mean, I think Beyonce was just recently in the L&N Stadium out there where the Cardinals play football. I don't know, maybe she had 40,000 people. Well, like almost three times that number of people are going to die every year. And the people that were in that audience are the same age range of the people that are dying from the opioid crisis. It's really, I'm not sorry, the overdose crisis. Calling it an opioid crisis. It's an overdose crisis from these other agents I talked about. But it's primarily a problem with younger people. And it's a tragedy when anyone dies, but when somebody who's in the prime of their life or younger dies, it's such an incredible loss of opportunity, loss of future experiences in life, and also their families, their loved ones. It affects so many people. Addiction in this crisis is not just affecting the person who is using, it's affecting the families, the friends, the loved ones, all of us. And it's taken a tremendous toll on not only the soul of our country, but also the economics of our country. It is a major issue that we have to attack. We have to get this under control, and there are ways of doing it. And I know we're going to talk about that during this conversation we're having. So thank you. That's how I'd like to get started.
All right, Gene, you want to get started?
Yeah, I'm Gene Shobley. I'm a retired general surgeon from Campbellsville, Kentucky. I'm on the graduate faculty at the University of Louisville for many years. And again, what I say does not reflect the Department of Surgery at University of Louisville or Taylor Regional Hospital. Well, I want to start off with, can you give us the numbers of the increased overdoses that are happening in the last few years? And are they increasing, and why are they increasing? And then I got a second question. What's the recidivism rate of those who are addicted to drugs?
Okay, well, first of all, the numbers that are increasing, it was over the last 10 years, the overdoses were increasing, on a steady basis. They kind of leveled off before COVID hit, but it leveled off at around 70,000 or so, which is more than died in the entire Vietnam War. So every year we were losing more than died in the Vietnam War. And then COVID hit. And we know that when there's upheaval, social upheaval like this, when there's a crisis that in a population, there's stress involved and things happen. And so the numbers went up. The numbers went up precipitously. Part of it was because people did not have access to the treatment that they were getting for their addiction, because they weren't allowed to see their doctors, they weren't allowed to go places, and they weren't allowed to have the meet and have the meetings that they were having with their therapists even and whatnot. And so and the harm reduction, which is the Narcan distributions and clean needle exchanges and things of that nature, those were kind of on hold for a while all around the country. So the numbers started going up, and they got up above 100,000, which was record during COVID, and they've kind of stayed there. They've kind of leveled off though. And now that COVID is over, we've learned lessons during that time about what works and what doesn't work. And by the way, telemedicine, we found that really works, and we'll talk about that later probably. But we've learned some lessons. It has leveled off. It's about a little over 100,000 people per year now that are dying. And then I think we have a strategy now. And if we can employ it and actually have the courage and the strength to follow through with this strategy, I think we can get those numbers going back in the right direction. The recidivism rate, people that use drugs and have addiction, you have to understand that addiction is not a moral issue. Addiction is not something that these people necessarily want to do. It's by the time addiction sets into their brain, it's almost like brain damage. That reward center in their brain, they call that subconscious area of your brain that kind of moves you to do things to that are helpful for yourself, like eating or finding a mate, or things that are just pleasurable for yourself. Those are there for a reason. They're subconscious, but they're connected to the frontal lobes of your brain. So, we're not always acting on our impulses. With addiction, that subconscious part of the brain is hijacked by the drug, and the compulsion is many times stronger than it would be normally. And it's damaged to the point where when they don't have the medication or the substance, then that they're not going back to normal. They go back to less than normal. So they feel horrible. They're in withdrawal. They feel that have a low self-worth, and it's just a horrible place to be. I've heard it described as a hole in your soul when that happens. But there's also a disconnect between that part of the brain and the frontal lobes, the executive functioning. So it's almost impossible for these people afflicted with this disease to override those impulses. And it's a neurobiological disease. It's not a moral issue. It's probably incurable. There's treatment though. But once that damage occurs, it's probably going to be there for life to a large extent. I mean, not in everybody, but to a large extent. So when you view it that way, when you view addiction as a chronic illness, a chronic disease like hypertension, like diabetes, like people with heart disease, I mean, they're going to have these diseases, these processes, probably for the rest of their lives, but you learn to manage it, you learn to have treatment. But as we all know, not every patient that with heart problems or with lung problems or diabetes is always compliant. And sometimes their disease comes back. And, we don't blame them or say that they're, bad, or we shouldn't treat them if they relapse and, things go worse again. So when you view addiction like it should be viewed as a disease process, you view it that way, then when you have this relapse occur, which is the recidivism I guess you're speaking of, then you understand that we need to just get them back into treatment and get that treatment going again, and the treatment is effective. So over the course of somebody's life in treatment. I don't know what the exact rates are, but I know that it's more than 50%. You would expect that somewhere along the line that more likely than not somebody's going to have a relapse. And the idea is that when they do, you have the tools, the support ready for them, and get them right back into treatment if they've gotten out of treatment, and you know, get them healed again. We have the ability to do that. We have the medicines to do that. We know what works, and we need to view addiction as a chronic disease process and not a moral issue.
You know, Pat, a few years ago, one of the retired chairman of the surgery department was a health commissioner for a while. And he gave a talk at the Louisville Surgical Society and indicated that the recidivism rate in Kentucky, and this was a few years ago, was 70%, which is, it's really scary. Well, listen, before we get into the strategy and the treatment, I'd like to get you to talk a little bit about fentanyl, how much of an impact this is compared to some of these other medications or drugs, horse treatment, whatever you mentioned. And the way I understand this is the chemical, as opposed to the medicine, in the fentanyl drug issue, comes from China, and that is then transported to Mexico, where it's manufactured in the cartels, and then the cartels are getting it across the border. And again, my understanding about this, these are not the immigrants that are swimming across the Rio Grande River and trying to climb over those pontoons or whatever they've got out there now, but it's coming across the border in trucks and cars and other things. So give us a kind of an overview of the fentanyl issue, from the percentages of people and how much of an impact it is, who's it involving mostly. And so I'm assuming that these are not people who had some kind of surgery and then got opioids and then have moved on to fentanyl, but these are people that are buying it on the streets just for recreational purposes.
Right. I don't think that I've heard that people are buying fentanyl off the street, knowing that it's fentanyl. In fact, Kentucky just passed a law that for the first time allows us, and by say us, I mean that are in harm reduction like myself, we're allowed to distribute Narcan, but we're also allowed to distribute these testing strips. So people that use can actually test the drug supply and see if there's fentanyl in it. They're fentanyl testing drug strips. And the legislature in Kentucky joined many other states, and they got in line with the federal government, the recommendations. And in that regard, we are current in Kentucky. We are.
Well, how do you use it? If you have a pill, do you put the strip on the, how does that work?
I think it varies. They usually, when someone's going to do, they're going to inject the medicine. So I think it's you test once it's liquefied, you test it how you're going to inject it, and then they're not going to inject into their vein a drug that's 100 times more potent than morphine. That's very, very fast acting. So the fentanyl, within a minute or so, can make them stop breathing. And then if somebody's not there to reverse it with Narcan or give them rescue breathing or call 911, you lose them. They're going to die. And that's happening in record numbers. But fentanyl is extremely potent. What happens is that when there's a prohibition of a drug, we've seen this throughout the history of the United States. In fact, there's a term for that. I think it's called the iron law of prohibition. And we saw this with bootleggers with alcohol. Whenever there is a prohibition on a drug like this, something of this nature, or when there was a prohibition on alcohol, for example, people will still get around that by replenishing that supply with another drug or another substance that is more potent and actually smaller. And think about a bootlegger. That's people, when all the alcohol was outlawed in the country, people would put it in their boot, and they would hide it at a flask or something, and they were called bootleggers because they would get more potent alcohol, and they'd bring it in and they would distribute it. Well, that's kind of what happens with the opioid situation. In the last decade, the amount of prescribing of opioids for pain and for this, for example, has gone down about 50%. So that's a really, I think, for people that thought that the supply was way too much in the community, which I believe it was. That's a lot of progress there. But did you know that in the last 10 years, while the prescribing of opioids has gone down 50%, the number of overdoses have gone up 300%. So the concern is that what has happened is, as you've gotten away from one source, it's been replaced by fentanyl, which is more potent. And so the drug cartels can bring in just a small amount, a couple bags of fentanyl, and that's like bringing in a truckload of some of the other medicines that they had brought in, the prescription pills in the past or whatever. So it's really they've learned to bring in this much more potent chemical and bring it across the border in smaller amounts, but yet it's much more potent, 100 times more potent than even morphine. So that's what we're dealing with. Yeah, they've figured it out, and that's why the issue is we do have to address the supply coming across the border, but we got to address, why do we have this demand for this in this country? What is it about the way we live our lives and the human nature? What is it about humans that we're looking for? There's a demand for this, and it has to do with some of the factors that make people turn to drugs like this. People have to have other reasons for self-worth. They have to have things going on in their lives. They have to have stable relationships, less crisis going on. And then when they do get exposed to something like, they take a pill or they get exposed to something that could possibly cause addiction, and they start having those tendencies, which about 6% of the people will, approximately. If they get exposed to it, they'll like the medicine. They'll like an opioid rather than just, use it just for pain. They'll kind of like it too much, but they may have a genetic predisposition to becoming addicted. So what we have to do is we have to have resources available to help those people, not just medical, but also educational resources, so we can, treat this as a health crisis and not a criminal crisis. When you criminalize the person using the drugs, then you're not treating what the root cause of it is. And the root cause is that we have a demand in this country for addictive chemicals, and we have to find a way to diminish the demand, and also treat the people that get exposed to it.
Let me ask you a question. How do we go about decriminalizing drug addiction? Because we've got huge numbers of people in prisons and jails that've been convicted of selling drugs and using drugs, and it seems to be getting worse rather than better.
Well, there's a whole range of options there, and there are some people that would say we need to legalize all of these substances, so they and regulate them, but take it out of the criminal standpoint. And there's some truth to that. I think that would help to a degree, but it's not going to be something that I think can go unregulated. What you can do is when somebody is caught, or when they're arrested, or when you find that somebody is using, or they've given it to somebody else or whatever, depending upon the circumstances involved. Obviously, if somebody is distributing on a large scale, then that's pretty evil. That's pretty criminal. But if somebody has given some to their friend or whatever, and then there's an issue there that it may not be a criminal aspect. It may be something that he's just trying to help out or whatnot. And when they do get arrested, or when this comes to the forefront, it should be dealt not in that you're going to prison or going to jail. It should be dealt in the standpoint of, you know, we see this as an illness, and so we're going to move you into a capacity where you can get treatment for this, or we're going to, you know, figure out why this is happening. Because if you don't do that, they're going to get right out of prison, right out of jail, and if there's no treatment, they're going to go right back into using, and you just, you know, probably made the problem worse, actually.
Now, Pat, are the sellers and the users, do they fall into the same categories? Because you know, I don't know enough about this, but it seems to me that the people who are selling it, distributing it, are a different level of concern from a criminal standpoint than the user. Or is it, can you make that distinction, or am I missing something here?
No, you are right on with that. It's the people that are selling this poison. It's poison. People that are selling it to people are murderers in many respects, and they should be dealt with very harshly. Users, however, users are almost exclusively people that have this disease of addiction, and they almost feel like, in many respects, they're going to die, or they would rather die than not use this the chemical or whatever that they need. As I said, it's there are people that, you know, I know, and people of who's had children or people in their family, that great individuals that have been working programs and been free of drugs for a while, but then they have the relapses or whatever, and then if they get the addiction again, if it comes back in a very strong aspect like this, they can't make the fight the compulsion to use, and oftentimes, you know, if they've lost that tolerance to the drug, then when they go back to using, they go back to using what they thought was okay, that they could tolerate, but that'll kill them because they've lost the tolerance to it. Or they could have some of this adulterated supply that's got the fentanyl in it that's too powerful. That happens so often, and that's a very common reason why people overdose and die, uh, you know, using these drugs.
You talked about strategies for new treatment. Can you tell us a little bit more about that?
Okay, the White House, actually, the current administration has a drug policy which has outlined, they call three pillars of their drug policy to fight this, and I think it makes a lot of sense. The first one is prevention, and the second pillar is harm reduction, and the third pillar is treatment. And I'd like to add a fourth pillar, and that is supporting people after the treatment. So think about it. You want to prevent it. You want to make it, just get the word out, educate people that it is just dangerous. It is not something to be messed with. It's not should not be recreational, and that enough people develop this disease of addiction, and it could happen to anybody. Nobody is immune from this. I don't care what your background is, your socioeconomic background, how rich you are, how poor you are, what color you are, your ethnicity. Everyone is at risk for this. And we know that also certain groups have been more affected by this. Certainly the Black community has been harmed by this, the susceptibility to it. Women, in a way, that have a different set of susceptibilities. Poor people, you know, don't have the resources sometimes to get the treatments they need. It is so there are communities that have been affected more greatly, but nobody's immune from this. And every family, I don't care who you've been touched by this. So the pillars are That's prevention, it's harm reduction, and it's treatment.
Well, how do you get that message out to these different groups? Because you've got, a number of different socio-economic groups in there. Are they all going to hear the same message? Is it something that needs to be done through churches? I mean, that seems to me like a really challenging activity.
Well, I think, I'm not sure churches we should rely on them because it's not a religious issue. Not really even a moral issue. It's a biomedical issue. And you can't glamorize this. There's so much in the media now. There's so many, movies and TV shows and songs and that just glamorize drug use. And that's not new. That's been going on for a long time. We really need to move in the other direction. So we got to rely upon the people out there that are giving messages, primarily to young people as well, because when that younger people are the most susceptible. They have the brains that are really still developing, and a young developing brain is an adolescent or a young adult. They're at the greatest risk of being damaged by being exposed to this. So we really have to make it cool to not do this. And it's not just say no. I mean, we have to, as a society, decide that we're not going to go down this road. So that's one thing. That's the prevention. And then the second pillar is harm reduction. When people do get exposed to this or they do develop a disease of addiction, you can't throw them aside. You have to respect them as being valued humans, as being valued members of our families, of our society. And they're just suffering from a disease, and we have to keep them alive. We have to have Narcan available so they don't die from unintentional overdoses. Nobody really wants to overdose and die from using drugs. I should say it's really, really rare. But we got to treat them. We have to treat any psychological illnesses, the mental health issues that are part of this as well. People have to have access to mental health services, and also buprenorphine and methadone, but especially buprenorphine, which is a medicine that now, without the X waiver, the federal government, as of January of this year, has done away with any requirement that a doctor have additional training or any kind of certification to prescribe buprenorphine from their office for anybody who needs treatment for opioid use disorder or opioid addiction. So we've brought down that barrier that's been there since the year 2000. And that's a tremendous thing. So we need to have more access to buprenorphine because we know that works. That can lower the mortality rate by about 50%. Think about that. How many drugs do we know can lower the mortality rate or save people's lives by 50%? There's not many cancer drugs that can do that. Certainly this is as deadly as cancer. So it's amazing that we have this drug, buprenorphine, but there are still barriers in its way. Kentucky is one of those states, my home state. Darn it, they need to either get rid of those buprenorphine regulations they have or drastically change them, because we are out of step with the rest of the country. And if you go on the website today, it still says you need that X waiver in your DEA license to prescribe. And there's no such thing as an X waiver anymore. It's gone. So we need to have our politicians listen to groups like the Kentucky Society of Addiction Medicine and experts in this field that say, diminish the barriers to this treatment that we know works. So we need to have the harm reduction. We need to have those services available, which we're getting. The opioid settlement is going to give groups like the Kentucky Harm Reduction Coalition some funding to get Narcan out into the community, to help with the clean needle exchange, to test people for hepatitis and HIV and pregnancy, so that people can not die from something other than an overdose, because a lot of health issues go into the lifestyle and the addicted to these drugs. Also, providing social services to people, because when you're living under a viaduct, or you're living in a place and around people that are just not going to be healthy for you. You need people need to have hope. They need to be able to, once their brain stabilizes and they're no longer craving these medicines so much, craving these drugs, get them the training, get them a good place to live, get them some transportation so they can get to treatment, so they can get their lives back. So
Pat, where does health insurance come into this issue? Because we're not dealing with people in a Medicare age range like all of us sitting in the room here. But these are young people. So do they have the health insurance? Are they on their parent? Can you give us a kind of an idea of where that fits into these management programs?
These things don't happen for free, unfortunately, and they should. This is a crisis. I mean, when we had COVID, I mean, you could get your vaccinations for free. You could get I mean, there was really no cost to the population for getting treatment. And why can't we address this crisis in the same way? Why can't we get together and say, this is a crisis, it's killing people in record numbers, primarily young people? Why can't we say it's not a moral issue? We're going to put the same resources and the same volition into treating addiction that we've put into COVID. Now, the difference is COVID was a virus, and I'll tell you what, the virus is going to virus. The virus did its thing. You can say the vaccines worked or didn't work. You can say the medications worked or didn't work. But we all know that a virus tends to, over time, work its way through the population and then become weaker over time. And we've seen that with COVID. But we have not seen that with the overdose crisis, with the addiction crisis. It's not getting better, it's getting worse. If you can equate the fentanyl or the opioid to the virus, the COVID virus got weaker. The opioids are getting stronger and they're killing more people. So we need to focus on a public health approach, much the same as we had with COVID. And I think that would work. But it is a barrier right now because buprenorphine is not free, and the cost to it gets in people's way. They still have to go to doctor's offices to get it most of the time. And if you have, I guess if you have no means at all, you can get Medicaid. You can if you can find somebody that will treat you, which we don't have enough doctors willing to do it right now. We need more. But if you can find a place to go have it done, like University of Louisville, for example, if you can get in, then you can get your treatment there. But there's so many people that are in the middle that don't have the resources. They're working or they're not working, but they either don't have insurance, they're underinsured, and they can't afford the buprenorphine. They can't afford the other things that they need. They can't afford the doctor visits. They can't afford the psychological treatment that is very helpful in this as well. I don't want to underestimate how important it is to have counseling, and even if it's just AA meetings or NA meetings, that's helpful if that's your thing, if that works for you. That's free to go to, but they need that mental health aspect as well. That costs money. So we need to have universal access to this care. We need to have no barrier to it, no economic barrier. We need to view this as an emergency, just like COVID was. Unfortunately, people still see this as a moral issue, and it is not. As a scientist, I can tell you, as a doctor, it is a disease process of the brain, and we have treatment for it. It works. We have to get people access to this treatment.
And one of the problems, and I've said this on more than one occasion on this program, are the politicians in the states, many of the states. I'm going to tell a story that I've told a number of times, that there was a general surgeon that both Gene and I know that about 20 years ago developed some hearing or sight issues and retired from his practice and ran for office and became he was a representative, wasn't he, Gene?
Yes.
Yeah. And he, for the state legislature, and about 20 years ago or so, he gave a talk at the Louisville Surgical Society. And there were two messages I remember taking away from this. Like I said, I've said this before. Number one was that making laws was like making sausage, and we've all heard that before. The second thing he said was that the average politician in Frankfurt does not understand all of the subtleties that you were just talking about. And we see that today with the laws that were passed that have to do with teaching whatever you're teaching in school, women's health care, and a whole bunch of ideological stuff that doesn't make any sense at all. That's a serious issue, and I don't know how we get past that. Do you think if we had a single payer system, Medicare for all, some of these issues that you've mentioned would be addressed?
Yes. Short answer, yes.
Can you give us a couple of examples of how that might work a bit better than the healthcare system we've got today, which is focused on extracting profit from every healthcare activity as opposed to treating patients?
Well, Medicare is not just Medicare. There are people that sign up for managed care plans, so when you do that, you then are allowing a third party to decide, whether or not they're going to fill or pay for the treatment that your doctor's ordered. It's called prior authorization. Private insurances do that all the time. But when you get managed care through Medicare, if you sign up for that, that could end up being a barrier. Plain Medicare, though, to my understanding, there's no prior authorization necessary. If your doctor writes the medicine, if it's on the formulary for Medicare, you can get it. I think Medicaid's kind of the same way. But Medicaid is different from state to state, and they have laws that create barriers. Kentucky, for example, I have an office in Indiana, and if I see somebody in Indiana that's Medicaid, and I write their prescription, they cannot go to Kentucky and have it filled and Medicaid pay for it because I am not a Kentucky Medicaid doctor. So they have to find a Kentucky Medicaid doctor willing to prescribe the buprenorphine, for example, even though they might like me and I have that relationship with them. They have to, I guess, pay for it themselves if they want to, get their medication. And a lot of pharmacies will not let you pay for buprenorphine cash. That's a barrier sometimes. They should. There's a problem if they don't. I think they have a right to, but for whatever reason, they don't want to be scrutinized either. They see if you pay cash for something like this, it's a red flag. So the pharmacies then don't want to provide it for it. So if you had a universal access to treatment like this, and when I say Medicare for all, I'm specifically with no prior authorization for treatments that we deem are necessary. It's like the VA. I mean, I get to go to the VA and I get to have some treatment there. I'm so lucky. Our VA is great, and there's ups and downs and pros and cons to it. And every system has an issue, but I want to really, tip of the hat to the docs and the staff, the people at the VA, especially in our neighborhood, in our area. They're fantastic. And but I go there, and if I need something, there's no prior authorization. If the doctor prescribes it, I get it. And that's the way we need to do. We need to eliminate that barrier, that third party between the physician or the prescriber, it could be a nurse practitioner or anybody that's allowed to prescribe this. There should not be a third party in there. That patients should be able to get that medicine.
Uh, you talked about the problem with fentanyl coming in from Mexico and the Mexicans get it from China. And I know you've been on several national boards. Is there any way the U.S. could stop that?
You're you're talking to a doctor here. I don't know. I don't know. It seems like it's whatever we try, they figure out something else. I know there are policies and things they need to do, but you've got to eliminate the demand. You got to decrease the demand, and that comes with educating our people and treating people that have the disease of addiction, so they don't need it, and give them alternatives like buprenorphine or like methadone. There's a law that's being pushed in. And Rand Paul, by the way, it's a bipartisan law. He's from Kentucky, and he signed on to this. So good for him. In this, they're trying to allow methadone, which is a very, very potent drug for treating drug addiction, opioid addiction. They're trying to allow specialists like myself to be able to prescribe it out of our office. So patients don't have to go physically to a methadone clinic every day and get the medicine from the clinic. They can get it like any other medicine. They can get it, from a doctor's office and have some supplies of it. So we're moving in that direction as well. And I'm very supportive of that. And I can say that the American medicine is supportive of that as well. So I'm really glad that we're moving in that direction. But we do need to we need to decrease the demand. And when we decrease the demand, we will then be able probably to make headway against that coming across the border.
Now you were increasing demand. Those are the prevention issues you were talking about earlier. Or is there something else that I'm missing about this?
That's the three things: prevention,
Yeah,
that's the education, and that's prescribing properly, and then people, avoiding, trying these medications, and that's where we need to have or I should say, these substances. So we need to have our culture move in that direction. Then there's harm reduction. People that do have the disease, we have to keep them alive, keep them safe, keep them healthy, so that they can get the treatment, which is the third pillar, and make that treatment universal access to that.
yeah. Well, I see the first pillar the most difficult. I have got 5 children, and when they when they were young, we had a lot of disagreements and communication issues, and that's so you got a bunch of older folks trying to get a message to a bunch of younger folks, and I'm still trying to figure out how that can be done in an effective way. When I'm looking back over my life, I feel like my children, they're all doing fine. I'm proud of all of them. My son is an F-18 pilot for the Navy, which is something you have some experience with, and they're doing well. But it wasn't easy, and I didn't get all these gray hair and wrinkles, from laying out in the sun. So again, my thoughts about I think that's the hardest thing. It's figuring out a way to get a message to this group of people who's, as you've said earlier, whose brains are still developing, and who often can be a challenge just to communicate with them.
Well, I agree with you, and it is incredibly difficult. And people that are great parents and loving parents have had children that, despite doing everything they can, have their children have become addicted, and many of them have died. And they're great parents, and it's just that points out this is a horrible disease process, and so there's no blame we should pass around. But certainly, it kind of boils down to these these drugs, they, in people that are susceptible, they replace something. They provide something that we're not giving them in society. And that's that self-worth, that hope, that idea that I don't need this, I can find some other way to move on in my life. And that starts when they're young. That starts with getting people uh, access to education and schooling and and structure in their lives and feeling like there are other things they can do. So from the if like if you're looking at a pyramid of this, the top of the pyramid is the people that, you know, are out there and they're injecting and we have to keep them alive so they can get treatment. But the base of the pyramid are the people that are, you know, maybe have nowhere to go, or they don't have much structure in their life, or they don't feel like they have much hope, either, socially or economically. We have to provide a framework for for those people so they don't look to something else like drugs to replace that feeling of self-worth, which is like fool's gold. If whatever feeling of self-worth they get, or that joy, or that, in a sense, euphoria from trying a drug like this, then after a short amount of time, it becomes, if they don't have it, they are in withdrawal and they feel horrible about themselves, and then it just takes over their life.
How
So
do you, how do you make that framework? Where does that come from? I mean, I agree with everything you've said. I'm just trying to figure out how you do that.
I
The
think it starts with
mechanism.
it. You've got to support families. You've got to support peer mentors. You got to support. You have to have people have a safe place to live. Communities that are safe, so the young people don't turn to gangs and things like that. Or you've got to have people that um, see other options. You know, and and this is across every socioeconomic community. I think it definitely is more prevalent in disadvantaged uh, you know groups and neighborhoods and stuff of that nature. But it's in everywhere. It's in the most affluent communities as well. And but it starts with giving young people other options, other ideas as to how they can find self-worth. And it's different. But it's that's kind of the idea of just say no. It doesn't work. you know or this commercial where this is, we show up, this is an egg and this is your brain, this is your brain on drugs. That doesn't work. You have to give people an an option, something else to replace that, something, another option besides trying that. That is, it's cool, that makes sense to them.
Well, I've seen families that were just essentially destroyed by drug addiction. The families were trying to help and actually thought they were doing a good job, but they've just essentially been destroyed, not only financially but mentally and socially. So, how do we help these families deal with this terrible problem?
Well, I think that there are groups like, you know, uh, you know, uh, not not just Alcoholics Anonymous, but they have an auxiliary group, and that where Families Anonymous, where you can find support there. Uh, I know that locally, Southeast Christian Church has groups like that for people that are not themselves suffering with addiction, but they have loved ones. There are other groups in town that you can go online and find them for families and for people that are, how do I support this person who is struggling with this disease, and not destroy my life as well, because it's there can be a lot of shame involved in this. There can be a lot of what did I do wrong? Have I not been a good parent? And that's not the case. And most of the time, I mean, it's by far, it's something that is outside the, your ability to control. But what you can always do is, provide structure, be there for, your loved one, um, and, support them in getting to treatment when and if they are ready. And to get them ready for treatment, we have to keep them alive, and we have to let them know there are alternatives and have the alternatives available. And this is where your universal access comes in. This is where your Medicare for all comes in. This is also where the harm reduction comes in. We have to.
Pat, we're down to the end here. Do you want to make any quick last minute comments? And then Mark's going to take us out.
I would ask people to, if they're more interested, to contact the Kentucky Harm Reduction Coalition. Don't have the phone number on right in front of me, but it's the Kentucky Harm Reduction Coalition. I'm on the board of directors there. You can ask for me. I mean, or there's certainly people there can give you an idea of how you can help. I tell you what you can do. Call some of these organizations. If you're a family member and you want to learn more about it, I know Southeast Christian Church is an example of one. You can call, go online, find Families Anonymous, things of that nature. Just learn more about how you're not helpless in this regard. But give us a call, get involved. We do at the Kentucky Harm Reduction Coalition, we do something called a kit making parties about every month or two. Well, you can come in and you can work with us and put together a little kit that has Narcan in it and some information about therapy and treatment. And we make these kits to distribute in the community, so that if anybody comes across somebody that they think has had an overdose, you can save their life.
Pat, thank you.
That's something you can do.
Thank you again. This was great. We'll do it again in maybe 6 months.
Yes, sir. Thank you.
Okay. Dr. Murphy, thanks so much. It hits home with me. I've got a dear friend whose 40-year-old son right now is going through some deadly times. So thanks so much for this info, and I'll pass this show on to her and Kentucky Harm Reduction Coalition for our listeners. For folks who want to learn more about Kentuckians for Single Payer Healthcare, you can go to kyhealthcare.org, kyhealthcare.org. You can also follow the group on Facebook and Twitter and Instagram. If you'd like to contact our chairperson directly, that's Kay Tillow. You can contact Kay at nursenpo@aol.com. nursenpo@aol.com. And you can call the Kentucky Harm Reduction Coalition at 502-537-6061. 502-537-6061. Thanks, Dr. Murphy. Thanks, guys. Another great show. For Single Payer Radio, my name's Mark McKinley. Thanks for listening.
Thank you.